gender affirming care. The goal is really to, let me get that off my middle of my screen. And the goal is really to focus on children, adolescents, and I did a little bit of a deep dive into what data we actually have on mental health outcomes. So we'll touch on a little bit of that as well. All right. No conflicts of interest. Of note, there are no medications that are currently FDA approved for gender affirmation and treatment of gender dysphoria, but many of these are used as kind of a global standard of care. Objectives will differentiate some of the different terminology. We'll enumerate criteria for diagnosis. We'll talk through kind of gender affirming care and what that means across the ages and discuss a little bit of consent. We'll touch on some primary care issues. I believe that the next grand rounds will cover that in a little bit more detail. And then we'll kind of go into the research and look at some of the health disparities and what gender affirming care seems to do in terms of mental and physical health. And then this is just to show that publications on this topic, particularly on transgender youth, have increased dramatically over the past several years. So it's really a topic being actively studied. So overall population, most recent numbers are that about 7.1% of adults identify themselves as somewhere along the LGBT spectrum. And there seems to be an increase in younger generations. As you can see here, kind of by generation, significantly more adults who are identifying themselves as along the LGBTQ spectrum. And about 10% on the most recent did call themselves transgender, or 10% of LGBTQ adults identify themselves as transgender, which is about 0.7% of total US adults. And then youth population is a little bit harder to get good numbers on. Looking at data in healthcare systems, it looks like it's about 0.02 to 0.1% of youth. But looking at surveys, which may capture a broader audience, particularly people who are hesitant to come into the healthcare system, up to 0.3 to 0.5% call themselves transgender, 4.5% gender diverse of adults, and then children, the numbers are a little bit higher, 1.2 to 2.7%, and a much higher number gender diverse. As for what that actually means and a little bit of note on terminology, we are constantly updating terminology, cultures change, so it's always possible that we're a little bit behind and not completely inclusive. First note is that many different cultures have various ways of expressing their gender characteristics, and it's considered pretty normal to not completely align with typical cultural presentation of sex at birth and not necessarily negative or pathological. Gender incongruence is no longer considered to be a disorder of its own. Gender diverse is a term used to describe kind of a broad set of people with gender identities or expressions different from what would be expected for their sex assigned at birth. And that includes quite a bit of different terms: non-binary, gender expansive, gender non-conforming, two-spirit, various others who don't identify as cisgender. And then transgender, and typically people whose gender identities or expressions not expected for the sex they assigned at birth, often used in people who see themselves as a kind of binary other gender compared to what they were assigned at birth. Of note, this should be used as an adjective, not as a noun or a verb on its own. And more recently, we're trying to use gender diverse to encompass everyone, as not everyone sees themselves within that gender binary. And a note that's included in the most recent WPATH standards of care is that much of our research, much of our data is English based on kind of Western conceptualizations and language. And we don't always have the right language to describe all the different gender expressions that may be cultural or linguistically specific. So kind of a basic intro of gender sex expression. Sex assigned at birth is typically what's written on the birth certificate, what's decided based on external characteristics, female, male, intersex. And then gender identity is your concept of your own gender. So agender, I identify as female, some people identify as male. There's a whole spectrum of non-binary, genderqueer, transgender, typically identifying as the opposite of their sex assigned at birth, cisgender, identifying with the sex assigned at birth, and then anywhere in that gender diverse umbrella. Gender expression is the way a person expresses themselves. That's where pronouns, clothing, presentation come into play. And that may not always match your gender identity, particularly if you're in a place where it's not safe to express yourself. And then sexual and romantic attraction can go anywhere from asexual, not attracted to in a romantic way, not attracted in a sexual way, to attracted to different, same, multiple genders, all sorts of different things on the spectrum there. And sexual behaviors don't always line up with how people define themselves, which is why when you're getting a history, very important to ask kind of actual details, what parts partners have, as opposed to making assumptions. And this is just kind of conceptualizing that in a different word. Awareness of gender identity actually starts pretty early, with kind of consciousness of physical differences pretty early, and then increased development throughout the ages and a sense of gender consistency, typically by 6 to 7 years old. Oh, was there a question on that? Okay. And again, some big milestones and then ways to meet them. So as children start to develop a gender identity, teaching them proper labels for their anatomy, allowing them to make their own choices, especially when they're very young. Trying to degender objects, degender things that don't have a specific gender, and really avoiding stigmatization, trying not to correct when children are calling something a gender, because that may be how they're experiencing it. And school age, kind of preteen, really creating safe spaces, thinking ahead, and then especially around puberty, really screening for body dysphoria, gender dysphoria, and kind of explaining in anatomical terms things that are about to happen with their body. And then by kind of early middle adolescence is when you really start thinking about relationships, sexual behaviors, consent, all of the things that we think about with our older adolescents. Typically, gender is pretty well solidified at that point. So gender dysphoria is specifically a state of distress or discomfort that may be experienced because of a person's gender identity differing from what their sex assigned as birth was or what would be expected based on their sex assigned at birth. Not all gender diverse folks experience this, and we really think that it is more a product of our social environment. As we know, in many places in the world, especially here in Idaho, gender diversity is stigmatized, which can lead to prejudice, discrimination, abuse, neglect, loneliness, which can then lead to psychological distress. Dysphoria itself is not necessarily inherent to being gender diverse. In the US, as you probably know, a gender diagnosis is required for treatment, and currently the DSM diagnosis is gender dysphoria, which is incongruence plus distress. And it does make it a little hard to study if a treatment resolves dysphoria, because that code will typically follow someone through their chart their entire treatment. So criteria for diagnosis in adults and adolescents, duration of at least 6 months, involving a marked incongruence between one's expected gender and primary or secondary characteristics, and a strong desire to be rid of those, be seen, treated, have the sex characteristics, or believe you have the feelings of the other gender, accompanied again with distress or impairment in social, occupational, or other functional areas, and then specify disorder of sex development or post-transitional. For children, fairly similar criteria. Again, 6-month duration, a strong desire to be of the other gender or an insistence that they are of the other gender, and then some criteria here, different things that you might see that are pretty consistently opposite the gender you would expect, and again, seeming to be associated with distress. This can often worsen as pubertal secondary sex characteristics develop, but that is not a diagnostic criteria. And something to think about at your early well child checks, even as early as 3, is start asking about gender. Ask the parents, ask how they play in a very open way, not stigmatizing, not trying to push them any direction. And then particularly if they do have behaviors or seem to have an identity that wouldn't necessarily be expected, really check in on school issues, bullying, anger, isolation. And I think it's probably possible to have pushback with families, but definitely reasonable if you can, and in a safe space, ask children themselves. Do they feel like a boy, girl, neither, pronouns, names? And then same with adolescents, ideally you're doing a heads exam and having time with them separate from their parents to really ask how they feel about their bodies, how puberty's been, if they've had dysphoria, if they've questioned, if they notice that they don't feel like what's developing in their body is appropriate for them. And particularly in adolescents, high risk for various mental health concerns. So really should be screening if you at all possibly can. And then a little bit of a difference between gender expansive or gender diverse children, which can be kind of a whole variety of behaviors, preferences that are not gender typical, and maybe a desire not to ascribe to whatever strict assignments that you would expect for their sex assigned at birth, but not necessarily distressed or sometimes distressed because of bullying. And then when we think about transgender children, we think of really persistent, insistent, distressed. These are the kids that you might think about initiating treatment with. So gender affirming care as a framework involves quite a broad different array of affirmations. Often we think about kind of the medical surgical side of it, but it really starts with social affirmation, allowing children or adolescents or adults to dress the way they would like, adopt a name, use pronouns, restrooms, bathrooms, making sure they have safe spaces. And that actually has a really huge outcome on mental health effects. And then legal affirmation is something that we can help with in the clinic office as well, as kind of your change on gender markers, name on official documents. And then when we do start the medication treatments, the first thing we usually think about is puberty blockers or blocking puberty progression. Typically both allows more time if there's question, if the secondary sex characteristics seem to be worsening dysphoria, but the vast majority of people who use puberty blockers do see them as the first step of the transition. They're considered very safe, considered reversible, and they really allow you to prevent those permanent changes that can cause a lot of dysphoria. And we'll talk a little bit more in detail in a moment. And then medical affirmation is generally when we're thinking of our hormonal treatment, so masculinizing or feminizing hormones, androgen blocking, and then there's other procedures, skin procedures, hair procedures that can be done, and then surgical affirmation. And not all folks who are transgender or folks who choose hormonal affirmation, medical affirmation will choose to go down the surgical route. Some will choose some surgeries, but not all. It's a very individualized process. And that can be splenectomy, mastectomy, phalloplasty, vaginoplasty, as well as other plastic type surgeries that help them appear more as their gender identity is. Criteria for treatments from WPATH, which kind of sets the global standards of care. Again, marked, sustained incongruence. The World Professional Association for Transgender Health does not necessarily believe that you need to have a diagnostic criteria, but in the States, we do have to have that diagnostic criteria. Obviously, capacity to consent. If there are mental health, physical conditions, or possibly other things that are making it a little difficult to tell if someone truly has gender dysphoria, those need to be assessed, ruled out. And with medical risk, there's not necessarily hard contraindications, but definitely those risk-benefit discussions with patients. If there are risks you can reduce before you get started, that's recommended. And then a big part of this is that once you start medical surgical treatment, there are likely irreversible effects on fertility and reproduction. So really feeling confident that they either don't want to explore sperm banking, egg storage, or they have done that. It used to be that you were required to have a certain number of letters from a mental or medical professional prior to medical treatment, and then more letters usually for surgical treatments. The most current standards of care actually say that letters are not required if a provider is comfortable making a diagnosis, comfortable initiating treatment. And if letters are required, it should only be one letter for adults from someone who has competency in assessment and treatment of transgender and gender diverse individuals. For surgery, typically recommended that people are stable on their hormonal treatment for about 6 months, sometimes longer if that would make surgery, like top surgery, a little bit more effective. But if it's medically contraindicated or not desired, you don't have to be on hormonal treatment if your goals are just for surgical treatment. And then for adolescents, similar criteria. In Idaho and in most states, you do need parental consent in most situations. demonstrating emotional and cognitive maturity, able to provide informed consent themselves. And then again, addressing mental health concerns, addressing physical health concerns, discussing fertility preservation. And then for puberty blockers, the requirement is to be Tanner stage 2, confirm that they're actually in puberty. Often this will worsen their dysphoria and kind of provide more evidence for that diagnosis as well. Hormones, we typically start around 16, but you could start younger. If you start puberty blockers at a younger age and you don't want to have multiple years on just pubertal suppression. And then for letters, again, if letters are required, they do recommend one letter, but from a multidisciplinary team with both medical and mental health assessment prior to hormonal or surgical treatment if that's required by the practice. And then for children, there's a few different recommendations. The big one being that prepubertal children are not eligible for medical intervention, but there are all sorts of other things that might be beneficial for them. As we discussed a little, it can be very normal to have kind of diverse gender expression. Exploration is a normal part of development and does not always mean that a child will assume a transgender identity later in life. Like I said, no medical intervention, but psychosocial supports, family support, education can be really helpful. And the provider role is really to, in a non-biased manner, without a goal of any predetermined outcome, to assist in exploration, connect them to resources, and really support the family. Comprehensive assessments should be done looking at gender identity expression, the child's strengths, family strengths, challenges, conflicts, experiences of rejection and minority stress, even in children, and then could consider caregiver, child, and family psychotherapy if this seems to be beneficial, seems to be able to help with resilience and well-being, and then age-appropriate education for the child on gender identity, gender development, and then education for the family. A big part of the newest standards of care are responding supportively to a child who desires to be acknowledged as the gender that matches their internal gender identity, or social transition, which we'll talk about in a minute here. And again, providers can discuss the risks and benefits, help walk a family through that, and then provide information about what medical treatment would look like as children approach puberty. A note on conversion therapy, which most of us have probably heard of at this time. This is any therapeutic, or quote, therapeutic attempts to compel a gender diverse child through words or actions to identify with or behave in accordance with the gender associated with the sex at birth. The rationale is that children are malleable, and if you can make them live as a cisgender person, you'll relieve the burden of stigmatization. And it really prevents children and adolescents from identifying as themselves, fully expressing themselves. And it has been shown to be not only unsuccessful, obviously this is gender identity is something you can't change. All you're doing is forcing the child to live not truly as themselves. It's unsuccessful, has been shown to be harmful, and is not a mainstream medical practice. Some recent stats about 6% of youth in 2021, and the most recent survey the Trevor Project did, were subjected to this, and 11% have been threatened with it. And just to really highlight that this is not considered in the medical guidelines at all. Multiple different associations, the American Academy of Child and Adolescent Psychology, the AMA, the AAFP, and the American Psychiatric Association all oppose this. The AMA supports a national ban on it. The providers who are supporting it are really out of line with the general medical community. And the APA has officially opposed it in their policies since 1998. So we've had data for a while that it's not effective. In terms of family support, you may often hear family asking if they can wait, will the child outgrow it, is it just a phase? And really the better question is, how do I help my kid? The watch and wait approach really ends up prolonging dysphoria. The idea is that most children with gender dysphoria do not become transgender adults. When people say this, they're often kind of looking at kids who are exploring, maybe more gender diverse, but not really those kids who persistently have a gender identity that's different than their sex at birth. Watching and waiting tends to limit transition based on age rather than assessing maturity level, whether or not the child seems to be ready, ignores their wishes, and ends up prohibiting full self-expression and waiting too long into puberty, can increase dysphoria and makes it a little harder to transition later. Valuing children for who they are as they explore, whatever their gender identity is at the moment, fosters secure attachment and resilience for the whole family. So for providers, really helping family and the child, psychotherapy if needed, kind of helping family transition themselves and understand this process, getting family connected with support, and then planning ahead. Both families and providers can kind of help with that school planning, work planning. We can do letters if needed for schools, and then on a bigger picture, advocating and watching out for safety. So social transition is a process where people change their gender expression to match the gender expression that matches their identity. This can include names, pronouns, clothing, hairstyles, speaking, voice training, kind of style of walking or movement, essentially how you move through the world. And it's actually seems to be pretty beneficial for youth to socially transition when they feel ready. There's several different studies that show worse outcomes in youth who are not able to transition. There's a study in pediatrics in 2016, talking with families, and then an update using an anonymous web survey. And overall, significantly improved anxiety, depression, and self-worth markers in children who have socially transitioned to about developmentally normative levels. It looks like depression is statistically just below the national average. Anxiety was kind of statistically just above the national average, and really decreases those kind of internalizing depressive symptoms. And Journal of Childhood Development did a big study looking at a few different kind of gender tasks in children. Socially transitioned youth, overall behaviors were pretty similar to non-gender diverse children. Statistical significance in terms of gender diverse children saying, I was that gender, but now I am this gender. But then kind of similar amounts, about 97% of all children said, I am this gender and I will be the same gender in the future. And then overall, very similar kind of preferences for toys, behaviors, dress, the way we would expect with non-gender diverse kids. So overall, social transition doesn't seem to affect major developmental understandings of gender in that sense. Pediatrics just did a study looking at retransition rates. Overall, pretty rare, about 7.3% retransitioned in some form. Some of those transitioned to a more non-binary or other diverse expression, about 2.5 that ended up retransitioning back to cisgender. And of those, the vast majority who ended up retransitioning had transitioned prior to 6 years old and then retransitioned prior to 9 years old. I didn't see specific numbers in there on regret, but I do believe they had a phrase in there that they didn't get reports of regret of having transitioned, even if they did retransition. And then the Trevor Project is a major resource that does a lot of surveys and has a lot of resources for LGBTQ youth. Actually, statistically significant reports of lower suicide attempts when your pronouns were respected by everyone you live with, if you're able to change your name, your gender marker, and if you're in affirming spaces. A study in 2020 in pediatrics showed that those who transitioned at an age older than 15 years old had worse health outcomes in terms of depression, self-harm, suicide, and psychoactive medications. So there seems to be a notable age component if children are allowed to transition when they first feel ready, as opposed to forcing them to wait. And then an interesting study in pediatrics in 2019, overall gender diverse kids have a much higher rate of locker room and restroom sexual assault in children, but there was significantly increased risk in restrictive policies where you were forced to go whatever matched your sex assigned at birth, even if that's not how you're living or presenting or what your identity is. Puberty blockers. This has kind of been a big topic recently. Puberty blockade for children with gender dysphoria is actually recommended by a number of different medical societies, including the Society for Endocrinology, WPATH, AAFP, and the AMA. It is typically initiated after Tanner stage 2. One, to make sure they're in a point where they'll respond to medications, and also because that experience of physical puberty may really help a child with their gender identity development. And it is possible to initiate it later if someone is uncertain about desire for steroid hormone replacement or not quite ready to start that, but wanting to kind of halt puberty where they're at. Tanner stage 2, so breast buds or 4 milliliter, 2.5 centimeter testes. And this is different from body hair, adrenarche. So just making sure you're at the appropriate Tanner stage. Typically with GnRH blockers, which can be injected or implanted. So GnRH agonists, gonadotropin releasing hormone agonists, typically in the body in a pulse fashion. Continuous use inhibits gonadotropin secretion and essentially suppresses ovarian testicular function, just kind of halts puberty. While we are only starting to study these in terms specifically of gender dysphoric children, these have been used for a really long time for precocious puberty, as well as endometriosis, and overall seem to be very safe and very reversible. The most common side effects are mood swings and headache, really rare, pseudotumor cerebri. I think there was 1 or 2 cases, and that was reversed with discontinuation. Doesn't seem to have cardiac effects in kiddos. The big one that people tend to worry about is bone loss. And it does seem that there is bone density loss during therapy, but it does not seem to be permanent. There was one study that compared it to Depo, which we widely use for contraception, and which we're kind of well aware of the bone density changes. And it found that the bone density was about similar to that. And there was a recent study that actually did look in gender dysphoric kids where puberty blockade was used, and it seemed that bone density recovered after hormone initiation, the same as we tend to see in precocious puberty once you allow puberty to progress. So treatment timeline, Tanner stage 2. Big things that you're going to watch are those hormone levels, as well as vitamin D levels, blood pressure, check your Tanner stages. And a typical treatment timeline might be a year or so of just puberty blockade, check a DEXA, monitor your bone density at the end, and then typically start adding back your sex steroids, which can be either testosterone or estradiol. And then you're going to be monitoring labs as you're doing that. There's a few different protocols for that. These are pulled from WPATH, and then there's a few other protocols that can be used. And for both adults and children, testosterone comes in topical and injectable forms, estrogen, topical, injectable, or oral. Of note, for patients that have ovaries, once testosterone is at a therapeutic range, that will generally suppress their ovarian function. However, for people with testes, even when your estrogen is at a therapeutic range, you do need an additional testosterone blockade. That can be done with GnRH agonists. It can also be done with spironolactone or other testosterone blockers. And then lab monitoring guidelines here. Big changes that you're going to see, both starting hormones as a younger person or starting hormones in adults. You get a lot of those changes starting early in the first few months, but most changes will take a couple of years to reach their maximum effect. And of note, your dose of hormones is not necessarily proportional to your effect, especially in adults. In children, you are generally kind of ramping up when you start the crossover with puberty blockade, you're kind of ramping up to those adult doses. And then the big risks we think about with estrogen is VTE, with testosterone is polycythemia, and then your fertility changes. For some primary care considerations, and I think this will come up with the next talk as well, creating a safe office space. There's actually pretty significant and horrifying disparities in healthcare for gender diverse individuals, both adults and children. Many people who have postponed or avoided necessary care, avoided screenings, experienced discrimination or mistreatment at the hands of a health professional. And that can be as blatant as care refusal, just straight up saying that you disagree, don't believe in it, straight discrimination. It can also be things like misgendering and kind of dead naming, refusing to use their name, consistently using the wrong pronouns in the office, which can be enough to keep people out of care. About a third of adults in 2020 had to teach their doctor about transgender people in order to receive appropriate care. So really important that as a primary care doctor, you can actually do all of this care. It's not horribly complex, but even if you choose not to, or your office chooses not to provide gender affirming care, it's still really important to know about it to be able to properly treat your patients. And then a big thing is creating a safe office space, thinking of your brochures, how you display your clinic and patients, having gender neutral bathrooms, making sure that you have pronouns, preferred names, and you're using those, most EMRs should have a space for those now. Ideally, having staff pronouns visible. If you are doing an exam on a gender diverse patient, and it is a more kind of sex organ specific exam, ask them their terminology, use a trauma-informed approach, just be really compassionate with it. And training all your staff, not just providers, but training reception, x-ray, everyone who a patient is going to come into contact with, how to appropriately treat people, pronoun awareness, all of that. And then the big thing is being humble. You will probably mess up. You will probably miss someone's pronouns at some point, and just admit what you don't know, don't make things up, and apologize when you mess up, and then learn from it. And then if you are providing their primary care, getting a full medical history, what hormones have they been exposed to, both prescribed or kind of online non-prescribed hormones, organ inventory, sexual history, but make sure you're not just asking for curiosity's sake. Make sure you know why you're asking. A big thing primary care providers can do for both adolescents and adults, consider menstrual suppression. GnRH will completely suppress menses, but then when you're starting hormones, sometimes you will have breakthrough bleeding. Ideally, a progesterone, but if a patient is more interested in combined or estrogen-based contraception, that's fine. Just have a risk-benefit discussion. Also worth noting that testosterone is not contraception. So if you have a patient with a uterus, making sure you're addressing contraception. Gender diverse folks do have significantly increased rates of STIs and HIV. So screenings and really asking about their practices, about their partners. And then for your primary care screenings, there's a few different guidelines out there. I have the UCSF guidelines in here. But for breast, cervical cancer, you're kind of considering the typical guidelines for cisgender folks for anyone with breasts, anyone with the cervix, prostate cancer, kind of a risk-benefit discussion. Osteoporosis, similar, UCSF recommends screening everyone at 65 and then any other traditional risk factors. For cardiovascular disease, as we know, a lot of our risk calculators generally use sex, and there's not a single clear guideline on that. If you have a patient who has been on hormone replacement since they were pubertal age, probably use their affirmed gender. If they initiated hormones as an adult, you can kind of use sex assigned at birth, you can use their affirmed gender, you can do a weighted average of the two, and then really treating their modifiable risk factors. As we've kind of alluded to already, major health disparities, a lot of minority stress from being in a society that can be discriminating. A lot of people do suffer violence and victimization directly because of their gender identity. Discrimination in families, being in non-affirming spaces can lead to kind of internal and external stressors, can lead to a lot of physical and mental health concerns, which can be balanced by resilience and having affirming spaces for people, having communities. These are data from the Trevor Project in 2022. About 14% of transgender youth have attempted suicide. Ages 13 to 17, that's up to 18%, compared to about 9% of all high school students. So significantly higher than the general population. And then pretty high rates of youth that have considered suicide in the past year, about 15% of your 13 to 17-year kiddos. So really major things to consider with all of your gender diverse patients. This is a study from the CDC in 2017, looking at violence and victimization experiences. I have not seen an update on this yet. So comparing cisgender male and female and then transgender identifying folks, significantly increased rates in feeling unsafe, traveling to and from school, threatened or injured in school, forced sexual intercourse, bullying by either at school or electronically. Higher rates of substance abuse, kind of across the board there. So especially as primary care docs, super important to screen for this, offer treatment, same as you would with any patient. As we've kind of alluded to, much higher suicide risks. And as we can see, kind of overall, all ages, much higher suicide attempts. Sexual activity, often younger, more, less protected, less contraception, and I think some of that stems from both either not realizing testosterone is not contraception, or again, just being hesitant to be in the healthcare system because of poor experiences. More transgender folks have been screened for HIV, but probably everyone should be, so that should be lower. And then this again, 2017 numbers, we probably have higher numbers identifying as transgender, but about 2% of high school students. And again, lots that feel unsafe, lots that have attempted suicide. And then some more data from the US 2015 transgender survey. The 2022 survey is actually currently collecting data, so we should have updated numbers on these in a bit. But as we've alluded to, significantly higher psychological distress and suicide rates, pretty big income and employment disparities, discrimination in the workplace, discrimination in employment, just feeling unsafe in your job, increased underground sex economy. So again, really screening for those things, really asking your patients for their sexual history, higher HIV rates, worse interactions with police, public restrooms. And I know this has kind of been a topic with multiple different state bans, but it really does affect where people are willing or able or feel safe to go out in public, which can be really harsh if restaurants, or as any place that you're going to go, only has kind of gender specific bathrooms. It can really keep people out of this public interaction and community. And again, significantly higher depression, anxiety, suicidality, self-harm across the board. And then I kind of took a deep dive into the evidence of what do we know, what have we been able to study so far around the effects of gender affirming care, both kind of social transition as we discussed and medical surgical transition. A note is that it is really hard to study these things. You obviously can't really do a randomized control trial because you can't really blind this kind of stuff. And most of these gender affirming care modalities are now considered standard of care. So you can't really deny them to someone. 2022 study was one of the first look back studies to look at adults who as children had wanted puberty blockers and did not have access to them. And that was a look back response. About 16.9% wanted pubertal suppression, only 2.5% received it. So pretty limited access, but significantly decreased suicidal ideation over the past year or the lifetime, severe distress over the past month, lower in people who did have access to pubertal suppression. Another study looking at access to gender affirming hormone treatment, again, decreased depression, suicidality, and suicide attempts, both kind of 13 to 24, and then broken down to youth at 13 to 17. And then Amsterdam has been kind of doing work with gender clinics for a really long time and studying it for quite a while. And looking at a collection of their data from in 2022, which looked back to about 2012, significantly improved depression, anxiety, peer relations, and suicidality after pubertal suppression. A little bit worse than the general population, but significantly improved to gender diverse folks who did not have access to that. Recent psychology study looked at self-reported well-being scores and suicidality scores and found significant improvement after hormone initiation. Another current psych report looked at hormone therapy. This one was not able to look at puberty blockers. And again, significant improvement in quality of life. They kind of got up and down on emotions, found that there was probably a kind of flat anger level, maybe a little more, but control was improved. And kind of looking at cognitive executive functioning, didn't seem to find a big difference there. 2015 Journal of Sexual Medicine looked at the Children's Global Assessment Scale, which is a pretty long validated scale, looking at a lot of different kind of psychosocial functioning, executive functioning, and found that at baseline gender diverse adolescents were much lower than their peers. And then after either 12 months of puberty blockers, or for those who were not quite eligible for puberty blockers yet, 12 months of psychological support alone, found that for both of those, significant improvements in overall psychosocial functioning. One of the concerns with puberty blockers is if we're blocking or delaying puberty? Are we blocking or delaying some of that emotional development, that kind of psychosocial functioning? And this certainly seems to show that overall improves it rather than delaying patients in that regard. And then looking at kind of some of the earlier data from the Dutch study, again, improved with treatments. Dysphoria persisted through puberty, even with blockade, which certainly makes sense, and then improved after hormones and surgery. And again, using a different tool to look at global functioning, overall improved functioning, improved both internalizing kind of depression, anxiety, and externalizing behavior issues. And there were no reports of regret during puberty suppression. In 2011 study looked at post-op outcomes and found that there were worse mental health outcomes for people who were treated in adulthood as opposed to adolescence. So again, shows that kind of earlier treatment seems to be beneficial. A couple of studies looking at the effect of state policy. A 2020 study in LGBTQ health looked at kind of graded states by their level of protective policies and found that in states that were not protective, the experience of victimization and discrimination increased suicide attempts. In states where there were protective policies, more affirming spaces, that correlation was not seen, which I think is particularly pertinent considering last year's legislative session and the fact that those bills will probably come up again. I think that it is definitely putting our kids at risk. The more we have those bills about, the less protective spaces we have. And then again, a recent poll from the Trevor Project, even debates restricting rights, even when those laws are not passed, youth report that it significantly affects their mental health. A vast majority of kids worry about access to medical care, worried about access to bathrooms. Again, kind of major things that are going to affect kids' ability to function in school, function in the world. And then again, multiple studies that show being in an accepting family, being in an affirming space, overall improves mental health outcomes, what you can anticipate for your future. And we can send this out. There's a few different resources here that are helpful for families. If families come to you and they're not sure how to approach their child's gender identity. And then here's a few different resources, both with guidelines and then a couple numbers that are helpful for support for youth and transgender adults in crisis. Any questions?
Thank you so much, Dr. Chisausky. That was very comprehensive. Really appreciate the thought and time. I know that Dr. Reagan put in the chat that he has a case he'd like to get some perspective on. So Dr. Reagan, do you want to unmute and go ahead?
Yeah, thanks very much. Thanks, Rachel. That was a very good presentation. I appreciate that. It illustrates, well, it sort of puts an exclamation point on something that happened in our community here in Pocatello just a few weeks ago. We had a completed suicide, 15-year-old trans-identified boy, and who had very, very good support at school, but did not have good support at home. And so it just shows that we have to kind of keep being attentive and keep trying to move this ball forward. My question, or my case, is a 14-year-old trans girl who basically came out of the womb transgender, identifying as female, assigned male at birth, has a cisgender male twin. She's now 14 and 4 months years of age. She's in the 9th grade. She started school in the 1st grade as a girl. She's been going to school all this time as a girl. She was started on Histrulin as a puberty blocker about 18 months ago. And so I just saw her the other day. And just a little bit of additional information. It does have a fair amount of difficulty with anxiety and depression. Some concerns about reactive attachment disorder. We're kind of working through that. She's on duloxetine. Besides the Histrulin, she's on duloxetine for mood. Overall, doing really well. Excellent student, makes straight A's, has lots of friends, and is doing well. My question is, it has to do with transitioning from puberty blocker to cross-sex hormones. And I'm one of the reasons for asking the question is that this kid's very small. She's 5'1". She weighs 83 pounds. Her height is at about the 8th percentile. Weight is the 2nd percentile. Both of her parents are relatively tall, and her cisgender twin is a full head taller than she is. And I'm wondering a little bit whether her hystrulin is causing some delay in her vertical growth. I've seen a few studies addressing that, and I know that the jury seems to be all over the place on it, but I have concerns about that in terms of pushing me to go ahead and want to transition her from the puberty blocker to cross-sex hormones. Here in Southeast Idaho, it's a very tough political area to very tough political climate to work in terms of physicians who are taking care of anybody, any transgender kid under the age of 18. And so I've been a little bit hesitant to start adolescents on cross-sex hormones before the age of 16. But in her case, but I have done in the past, and in her case, my inclination would be to do that sooner rather than later. And I'm just wondering how you all would manage her in Boise.
Okay, can I interrupt here? Are you hearing me, Rachel? Can anybody hear me? Okay, all right. So that is a very tough case, but I think that the first and foremost, you want to treat the adolescent as the one getting the informed consent, as well as long as that adolescent like understands the risks and benefits. Then I think that's a good point for affirming the gender, and then as well as if their parents are also supportive of the transition, then that's another point to start with the transition. Again, these guidelines, when they say they are recommending at starting at 16, remember that they're recommendation. Ultimately, it is the physician and the patient relationship. If the consent is given and they're all at well supported for that one. And remember that puberty really starts way before. If this patient is on Hystrulin, you know that the medication is working because there's no vertical growth. That's really like what you're looking for, is like there's no increase in puberty changes, and then you know that your Hystrulin implant is working. And I've transitioned like a 14 and a half, 15 before, and mainly because of like suicidal attempt, as well as like supportive parents as well. And so far it's been like it's been good and okay. And I mean, they've developed to like, I think that's been like 2 years already. So they're nearing 16 and they've transitioned fully well. So I think as long as both parties like understand and can give consent, and I think as a provider, like you can make that argument as well. And again, these are just recommendations. They're not hard and fast, like it has to be started at 16. If you feel that you can start much earlier and will benefit the kid, then I will go ahead and do that. That's my 2 cents on that.
Thank you. I appreciate that. Have you all heard, I'm sure you have, about some of the pushback in some of the Scandinavian countries? Sweden in particular, I think, has backed up a little bit on the age at which they start adolescents on either cross-sex or puberty blocking hormones. And I'm wondering if that, I know that that's been showing up a lot in some of the conservative media, at least here in Pocatello. And I'm wondering if that's going to have an impact on how things go for us politically moving forward.
I haven't heard like much about that, but I think, again, my duties to the patient and the family. So like I will respect, like, I mean, I will respect what the conversation accrues. And if during that conversation they want to start, then, and I think that patient is of sound mind and no other like contraindications, then I think it will start. But like, I mean, if it's banned or something, then then we'll cross the bridge when we get there. I already have backup plans for my kids who, if ever these laws become like very hostile in Idaho.
Yeah, I was reading a little bit about that as I was going through the research, and most of what I could find cited one of the studies that I shared showing that the psychosocial support and puberty blockers were equal, showing that again, in a supportive place, you're probably going to have better outcomes regardless. But the few articles that I found kind of arguing against it, I didn't see anything with really solid evidence. It did feel like it was more of we just don't have as much heaps of evidence as we would like. And again, I think these are places where they have a lot more psychosocial support and a lot safer places. And then for your earlier case, Dr. Reagan, the WPATH guidelines do specifically say in there, you can definitely consider cross-sex hormones earlier if you think you're having changes in growth, you have other reasons that you don't want to have years of puberty suppression. So I think the kind of global guidelines would well support you starting your patient on transition.
Yeah, thank you. I'm assuming you, Rachel, you and Marvin have probably better institutional support for treating younger trans people than Dr. Jessica Rowland and I do here in Pocatello, where we have a very conservative and somewhat nervous and antsy institution that we both work for.
That is correct, because we have patients coming all the way from Pocatello, from Garden Valley, from Lewiston, and Garden Valley. Yeah.
This is Suzanne, Rachel, and Marvin, or even Dr. Reagan. You might be able to help with this too. So I'm just wondering the supports that are available for families. So I know, you talked a little bit, Rachel, about counseling and that sort of thing for families, but are there support groups? Are there, I guess I'm just trying to figure out for family members, how do we best help them?
So Suzanne, so for family itself, one thing that I tell them is like, when kids are transitioning to their affirmed gender, they need their counselors, and just like the kids need their counseling, the parents actually need to undergo a counseling as well. It's really recommended, especially because it's a big change for their kids. It's a big change for the parents themselves as well. So I do recommend them. And we have counselors that can do a little bit of coaching for gender affirmed kids. So that's one option that I recommend. And then the other one is, and unfortunately it's based on Boise only. So the community center, if you do the website, the community center, they do have twice a month, every Saturday, there's a support group for transgender and gender diverse that's held into the they hold in the community center, so that it's a group discussion. And it's I think from 7 to 8 p.m. So those are my go-to things that I recommend to them.
Yeah, that's great, Marvin. Thanks.
We have a support group.
Yeah.
Sorry, we have a support group in Pocatello as well. Meets just once a month, and it's for trans and gender diverse people and families and their supporters and friends. And we've had COVID sort of knocked the breath out of it, but prior to that, we were having. We had as many as 30 and 40, occasionally even 50 people at a meeting, and so that's been very well attended. We've had a little bit of trouble getting back up and running after the the worst of the COVID era. One of the problems in our area is an overall lack of behavioral health providers. We have long wait lists for just general mental health, and we have a paucity of people, of healthcare providers who are truly knowledgeable about trans and gender diverse lives. And so it's a bit dicey here for us in the Southeast.
Yeah, well, and so thanks. I think I feel very privileged to live in the Treasure Valley, knowing that we have more resources available. So when I hear Marvin talk about patients coming to Full Circle from Pocatello or Lewiston or Garden Valley, just thinking about those families, especially in the smaller communities, as you said earlier, Neil, that's hard for the families as well as the actual patients. So just thinking about how can we support people across the state of Idaho, realizing again that I have the privilege of seeing patients at Full Circle Health. So Marvin and Rachel help me. I don't have to know as much about that, but certainly for patients and families, I think that's important. So thanks you guys for all you do.
And so this is Robin Sauter. Hi, Suzanne and Marvin.
Good to see you, Robin.
Yeah. So I trained at what was FMRI a couple years back. And so I'm working in Moscow, Idaho right now, and Michelle Hazen is also one of the other providers on tonight. And so we also have some groups, local groups, both in Moscow, Pullman, and Coeur d'Alene, that we have been trying to direct people to. So there are resources up here too. And so if there are people who are moving across the state, I am more than happy to also connect you with those groups. And then in regards to another mental health resource for individuals. So actually this was, I'm not going to take the credit, but Michelle Hazen was the one who brought up the resource Charlie Health. And I'm not sure if that's a resource that other folks are familiar with, but it's an online resource that accepts most insurances. They take patients up till age of 30 and are really, they present themselves as being very accessible to individuals, especially those during crisis. And so Charlie Health is another option that we have been referring people to, and they've been able to get in pretty quickly.
That's great, Robin. Thanks for sharing. And thanks to you and Michelle for the work you guys are doing up north. That's great.
Liz, I wonder if you should collect these and maybe put them on the AAFP website, or have a kind of resource collection somewhere that covers the whole state.
That would be a great idea. I have actually a couple of students who are from the Pocatello area who go to U of I, who I would love, Robin, to be able to have you see while they're during the school year.
Yeah, so I would say actually Michelle is who they'd likely see, because she's doing most of the healthcare providing at the school. So it'd be Michelle, and then she's off and I'm working in tandem with her. So that sounds great.
Great.
We do hope to develop sort of a policy and resource page on gender affirming care in the next maybe 3 months. So that is a resource that hopefully we'll be able to develop.
So can I say something?
Yes.
Okay, just a couple of things. A few things that I kind of learned. So the 2022 transgender survey is currently ongoing. So if you have any patients that are gender diverse, have them go to the transgender survey. So their names and their experiences will be counted. So like we need more. I mean, I tell all my patients to go in there like this past week, so like their voices can be counted. And then a couple more points for Dr. Chisausky's presentation. So the ICD-11 is now gender incongruence. So across the world, it's been using ICD-11, but we're kind of behind that. So there's lots of change, just different changes between nomenclature and where the gender dysphoria is like obsolete now. So it's gender incongruence. And then one thing that I learned about for legal affirmation, a credit score of a person starts when they're 18. So a lot of times when the child is already like fixed on their future gender, I try to tell them to change their gender before they're 18. So at least when the creditors like kind of check their credit history, then they won't be dinged about that they're previously male or previously female. That's just thinking ahead in time, because that will be important for them. So it's not going to be, because creditors will dig, but like they don't care about birth certificate, but like they would care if you have a previous gender. And then lastly, for the primary care, know that for patients who are on estrogen, The level of PSA level, if it reaches more than 1, that's already significant for people on estradiol, and that needs to be referred to a urologist already. So those are just an extra points from Dr. Chisausky's report. And the last one, don't forget the 988 hotline. It's a text message service for National Suicide Hotline. And I've been telling all the patients that you can text, you can call. And that's good for patients, especially if they're tech savvy. They can have like suicide help just by texting somebody. So don't forget that.